Right, my name is Roland Bellori. I'm joined by Professor Peter Hindrick, Ralph Lee and Stephen Heitman, and also we have Vikash Lalar, Amir Klein and David Tate here today, and we're discussing a review of the latest evidence and technique in endoscopic mucosal resection of large non-pedunculated polyp, the features that make a colorectal polyp difficult to resect and how to overcome these challenges. Describe surveillance strategies after resection and the effect of routine margin ablation on recurrence.
So why do patients get negative outcomes at EMR? If you try and cut out something that's cancer, if you attempt piecemeal resection where potentially en bloc would have cured the patient, or if you attempt resection and you can't complete it. So say that you see a polyp, you correctly assess it for risk of cancer and difficulty, and that's of course dependent on the competency of the endoscopist. The patient gets a single endoscopic attempt, complete adenoma clearance and is cured, needs to enter colonoscopic surveillance, but otherwise that's done, the problem is solved. If you incorrectly assess the presence of submucosal invasion, if you incompletely resect it, if you cause an adverse event during your incomplete resection, or if you cause the patient to have mischance of endoscopic cure, by which I mean that you don't do an en bloc resection when one was indicated, then potentially a patient who didn't require surgery needs surgery because the lesion becomes endoscopically unresectable. And all of these things cause increased patient and healthcare system adverse events, costs, lost work days, morbidity, mortality. So clearly defined parameters make EMR very difficult, and we've discussed what they are. Ask yourself the next time you see a polyp, is it invasive? Very important question. We've gone through it today. If you don't know how to do that, you will, certainly if you review the earlier comments today in the symposium. And is this lesion within my competency? John gave a nice talk about this earlier, and he talked a little bit about SMSA plus scoring, but I think I've delved significantly more into it now. So if you find a polyp and you go on our calculator and you think it's SMSA 3, ask yourself, are you a regular person doing EMR? If you start it, do you think you can finish? And if you do start it, can you manage the adverse events that might come with it? If it's a 4 or a plus lesion, think, unless you're a person who's performing referral endoscopy for this sort of polyp, think, should I refer this lesion? And certainly don't consider surgery until you have talked to, at least, or shown it to an endoscopist who's doing it all the time, because all of these lesions can be resected endoscopically. And from the most tertiary data available, if you take all polyps that they were referred, more than 94% of them can be successfully endoscopically treated. After all, it's the patient at the center. So if you consider the above, the patient gets a better experience, the department gets a better experience, and the training opportunities fall to the right people. Thank you for listening, Roland. I give it back to you.
Yep.
Sometimes I also use underwater because that can sometimes also float the lesion with the snare.
Open. You're going to need a lot of water.
Stephen, do you do that before?
Yeah, for sure. I think probably for that one it wouldn't be necessary, but I think it's a nice technique.
Yes. You see, I personally find, when I don't want to create a pseudopolyp resection, I create lovely pseudopolyps, and when I want to do one with an actual small lesion, it doesn't work so well. I don't think this has improved the situation much. I would be mindful.
So scars, we have some very beautiful examples here. So how do we inspect these? Indeed, we have published that a standardized imaging protocol can be used to detect adenoma recurrence. So first we will interrogate the edge of the scar with white light, and then followed by the center. So we go over the entire scar. We don't just look from afar, we go close up. And we go from left to right, from right to left, and we definitely also inspect the center. We perform the same routine with NBI, and we actually, as we already mentioned in the live case, we searched for a transition point where the pits changed from a non-neoplastic pattern to a neoplastic pattern. Very nicely seen here, and how small these recurrences can be. So these are some examples of scars without any recurrence in them. So you can see the vascularization, the normal vascular pattern of the colonic wall disappears. So in this case, it's a bit reddish because of the new vascularization, and also pale at the edges there. This is a relatively wide scar. Some are even wider, like this rectal scar, and some are very tiny, like this one. So you can imagine how hard it is to find this scar in a colon if we haven't described this properly.
And I think this is quite an important slide, and it shows that endoscopic treatment of recurrence is quite effective. At first surveillance, over 90% of these lesions were treated with a sustained robust effect over subsequent follow-up analysis. But again, remember that these are SMSA plus lesions, just by definition of them being previously attempted, and they shouldn't be attempted by everyone.